Oh, okay.
That way I won't bounce between. I'm just gonna sort of.
Okay, no worries.
You guys get the focus and I give like a second. Gotta stage my speakers here. Okay, so, and I'm gonna let you tip this way a little bit because they're all over there. This is, Suba.
Yeah.
And Dabney, and I'm so thrilled to have them. Dabney has been so helpful to me. She actually contacted me 2 years ago when we were trying to pull this all together, and I was so grateful to have somebody who knows the community and can hook us up with a lot of people. So a lot of the community conversations we've been able to have are really due to Dabney's influence and getting people together and the Rollins School of Public Health, which we so appreciate. So we're going to start off with a little bit of just having them tell a little bit about what they do in their jobs, and then come on in, just come on in, come in the center here so we've got people there. A little about what they do, and then I ask them to think about their response to the play, like when they finish the play, what comes to mind, what you're desperate to tell people as you watch the end of the play. And I'm just going to go out there and close the door so that we can have that. How's it going? You got a video going?
Oh yeah, we're good.
Okay, so I'm going to start this again. We're ready to start our conversation. Thank you so much for being here. And you're on. You go first, Dan. Oh, go ahead.
Oh, thank you. Hi, everyone. I'm Subasri Narasimhan. I usually go by Suba. I'm an assistant professor at the Emory Rollins School of Public Health, and I'm also an affiliated faculty with the Center for Reproductive Health Research in the Southeast. And what we do is specifically, I do global public health. I study sexual and reproductive health, but at RISE, we really study the impact of policy, particularly things like abortion restrictions, on different actors, so like the health system, individuals, particularly in the Southeast. So how are people impacted by abortion bans is really what some of my questions are about.
And my name is Dabney Evans. I'm an associate professor in the Hubert Department of Global Health in the Rollins School of Public Health at Emory University. My research is focused on gender, health, and human rights, and my background is in both public health and international human rights law. So one of the things that I do is look at the ways in which both international laws as well as federal and state laws trickle down to affect people's lives. And so that's where abortion law comes into place. Now Lisa asked us to talk about our reflections on the play, and first of all, what an incredible production.
Yeah, it was really
really, really powerful. And really, to me, very personal, because I'm from Louisiana originally.
Oh my gosh.
And in 1973, my mother was 16 years old, living in rural Louisiana, and she became pregnant. And she went to the doctor, very much like this. And Roe had passed. Roe was law by then. And she went to the doctor, and the doctor said, you have 5 choices. And my mother has told me this story, by the way, and given me permission to retell it, just so you know. And when she first told me this, 5 choices? What are these 5 choices? She said, well, the doctor gave me the 5 choices in his order of preference. The first was get married and have a baby. The second was stay single and have a baby. The third was adoption. The fourth was abortion. And the fifth was suicide.
Oh my gosh, really?
Whoa. So a medical doctor told my mother that those were her 5 choices after an unintended pregnancy. And when I think about the moment that we're in today, the experience that we saw Norma have here on stage, the experience that my mother had, and we hear this refrain of, we're not going back. What are we going towards? What kind of world are we going towards? What is the position that our healthcare providers will be in when a person presents themselves with an unintended pregnancy? And so those are really some of the questions that we try and grapple with. The other thing that comes to mind for me is my own pregnancy experience. And I'll just say, following up on my mother's story, that she's always, when she has told me that story, said that her own choice was a very important part of that. She was a young person, so she did not have the privilege of being, an adult that was well established. In some ways she didn't have privilege, but in other ways she did have privilege. She could have gotten an abortion if she had wanted. And we hear the refrain of pro-choice and pro-life, but really we also have to think about privilege as a part of that equation, as several of the characters brought into play. What are the financial resources that one has to have in order to be able to travel to have an abortion? But the other story that comes to mind for me is my own story of pregnancy and motherhood, which took place here in Georgia. And I was what they call advanced maternal age at the time that I had my baby. That meant I was over 35. And had a high-risk pregnancy, a pregnancy that I very much wanted. And my labor and delivery process was extremely dangerous and difficult. My own life was in jeopardy, and the life of my child was in jeopardy. And we have something that we call near misses in the field of labor and delivery, which is people that almost die during labor and delivery. And I feel very confident that if I had been a woman of color living in Georgia, which has the worst maternal mortality rate in the US, that I might not have survived. So when we think about what is the future, that's a very grim future, whether it has to do with either an abortion, a person that wants an abortion, or a person that has a pregnancy that can be dangerous as well.
Thank you, Dabney, for sharing, all of that. I think to add on, I had so many feelings while watching the play, and I was particularly struck by how nuanced you were not only telling the stories of Sarah Weddington and Jane Norma McCordy, but what is a state agenda or a legal agenda, and how does that really diminish our own personal stories and our own personal experiences in this, and how often the law doesn't extend to protect the people that are actually living through these experiences. How out of sync legislators and politicians often seem when they're arguing cases or they're discussing bills so far away from the lived experience of the people that are actually going through abortions in this country. And the truth is, when you think about a post-Roe world, there are many people in this country that live in that world already. That for them, the choice of abortion, it's a constrained choice. There's no choice. There's no availability. And I thought the nuances of how you captured each and every person's story, but then also the research that we hold so closely as a way to sort of talk about these issues. It was so clearly incredibly researched. I was just so appreciative of that.
And she was telling me what you guys were talking about. I said, "Oh, well, that's in the play, and that's in the play, and that's in the play too." So
Yeah,
when you can tell it in story, it sticks sometimes a little better for people. So.
yeah, and also the complicated feelings that a person with children has when they feel like they can no longer add to their family, when they feel like this is, having another pregnancy is not an option for me. And calling that out more and more, I think that one statistic about that most people who have abortions already have children. I think that that's sort of a statistic that we talk about a lot more now. But as I've thought about how I've come to think about abortion, that wasn't something that I had in the stereotype of the mind, who I thought would get abortions when I was younger. That wasn't who was discussed in my life as people who get abortions.
And you've done a lot of work on the heartbeat bill, and a lot about that. So you want to tell us a little bit about what it is, where it stands now, what the future is going to be of all that. If we assume something's going to happen in terms of Roe being overturned, we don't know how much or anything you want to say about that.
So many will know that in 2019, but actually prior to 2019, there was the introduction of these set of bills that were called fetal heartbeat bills. Those are that's the language that the anti-abortion side will use. We refer to them as early abortion bans. Basically banning abortion early in pregnancy, as was alluded to in the very powerful ending scene with the image of the very early stage embryo, not even fetus yet. And so in 2019, Georgia introduced legislation like this. And this is really modeled legislation, right? So to Suba's point about an agenda, there is an agenda, right? There is law that's literally, here's your boilerplate, take this to Georgia. Here's your boilerplate, take this to the next state. And that's exactly what happened in 2019. And so what we were able to do, almost in real time as that law was being debated, is actually do a little bit of reverse engineering about the argumentation that was taking place in the legislative debate. So what were the arguments that were being made by the folks that were saying, we need a law that says that abortion should not take place after the detection of cardiac activity in a fetus around 6 weeks, when most people don't know they're pregnant. By the way, another story about my pregnancy. I knew about 2 days after I missed my period that I was pregnant, and I called my healthcare provider to try and get a blood test, and they said, we'll see you after your 8 weeks. So most doctors will not even confirm a pregnancy with a blood test until after 8 weeks. How the heck is somebody supposed to get an abortion?
Yeah, and I mean, that's because, pregnancy and early gestation is so, like, spontaneous miscarriage happens, and relatively regularly. And so that's why the 8-week mark is usually used as a time when they'll call you into the healthcare center to have that.
So when we were looking at this 2019 legislation here in Georgia, we found a couple of things, and actually many of them were alluded to in the play. So one of them was this idea of the establishment of fetuses as first of all, the establishment of the heartbeat as an indicator of life. So what is life? This is the question time immemorial. When does life begin, right? Does it begin at conception? Does it begin at birth? And this is deep philosophical questions. But the argument in this legislation is that the heartbeat is a marker of life, right? And they even use end of life to make this argument, right? The way that you declare that someone has died is if they do not have heart, lung, and brain activity. You have to have all three, okay? In the case of life, the argument that they make is that the heartbeat is an indicator of life, and life means you're a person. The next step of that argument is, if you are a person, then these fetuses are a protected class, and that's where the 14th Amendment comes in, right? Even though the Constitution does say, and it got called out so perfectly in the play, born, it actually says you have to be born in the 14th Amendment. But the argument that the legislators made was that this is a protected class. And the really twisted part about the argumentation is, who are the other protected classes that have been protected by the Due Process Clause? It has largely been Black people, right, in protection of voter rights and civil rights, and LGBTQ people, for example, through the law that allowed for gay marriage in this country. So it's a very twisted perversion of this due process clause, trying to establish fetuses as a protected class. And in fact, in some of our research, there was quotes going so far as saying, well, there are several times in which the Supreme Court has been wrong. One was the Dred Scott case, which is a case that ruled that a Black man was not a human, basically, and is well known as being a very poor Supreme Court case, and made an analogy between that case and Roe v. Wade, saying the court has been wrong about this all along. This is a protected class.
And another thing that we did in this work was also to try to understand the use of evidence and scientific evidence in legal argumentation. And what we essentially found was that in anti-abortion rhetoric and anti-abortion law, there is no science. So we took apart the law, found the pieces of scientific evidence that they were citing, and then went directly back to the evidence that they were referencing to see if it was correctly described, and in no cases was incorrectly described.
Alternative facts.
It was all alternative facts. But what struck me about the play was, in the beginning scene, when they ask about a scientific document that proves viability, the same issue happens now when we look at both state, federal regulation, and at the Supreme Court level. There's no requirement for there to be this kind of scientific and accurate documentation. There's no fact checking. So there's different utilities of the law versus medical science versus the way that we think and use scientific evidence. But even more interesting is how the rhetoric in state-based abortion laws have changed. So in the 2010s, a lot of it was draft laws, meaning targeted regulations against abortion providers. So those were the regulations about the surgical centers, and that abortion providers needed to have state admitting privileges in hospitals that were close to them. Although none of those were necessary or improved safety or efficacy of the procedure. Abortion is a procedure that, and we're talking procedural abortion or medication abortion through pills, that has a less than 1% complication rate. That is 13 times, I believe, less than actual pregnancy and childbirth. And so we're talking about over-regulation of something in order to erase it, to erode it, you know? And so that nuance, like of medical and scientific evidence, and the language of evidence is being coined and used by anti-abortion like actors, but yet no true evidence is being used, no true scientific merit is being put forward.
And I just want to double down on the issue of viability for a minute, because this is something that's really in danger with the forthcoming Supreme Court case. Right now, science would say that viability is somewhere between 24 and 26 weeks. And the early abortion bans that we're talking about are nowhere near that point in pregnancy. So no one is saying that abortion is not a complicated and challenging philosophical issue. For some people, it's a very easy choice. For others, it may be a very difficult choice. But when we're talking about those late stages of pregnancy, right, that becomes where that philosophy is sort of there. Like, could this being live outside of the pregnant person's body? But when we're talking about these early abortion bans, there's no chance, right? There is no chance of viability in these early stages. The other thing that Suba mentioned that's extremely important, thinking about the future, because we don't want to be all doom and gloom here, is medication abortion.
Yeah.
We're not going back to pre-Roe. We're not, because we have something called medication abortion, which is pills that people can take. And we also have, unfortunately, what we are probably going towards is a system where we will have a very scattershot map in this country, right? So if Roe falls, as is predicted based on the leak, you'll have somewhere around 24 to 25 states where abortion will be illegal right out of the gate.
And inaccessible,
And inaccessible. So what that means is that people will have to travel, right? And it's still, Florida is a purple state, so if you're wondering what does that mean for Georgia, a lot rides on Florida. But there are actually abortion funds which are designed and set up to help people travel to be able to access abortion. So what we're going to have is we're going to have abortion meccas or abortion safe havens where people will be able to go to New York or California, perhaps Florida, and other states, right? But medication abortion is a really important piece of the puzzle here because, first of all, most abortions take place in the first trimester of pregnancy, and medication abortion is extremely safe, and in many places outside of the US is being self-managed by people. So we're not, what's that?
Affordable?
Is it affordable?
It is affordable. So that's another question. It's relatively affordable. So it depends on so there's technology advances. You can access medication abortion through the internet. We don't know legally, depending on what state, if there's going to be legal challenges to that. There's going to be legal challenges all over the place. Like we're unsure what the legal landscape will look like. But Dabney can show that medication abortion. But affordability is it's on average about a couple $100 for it. So when we're thinking about relative affordability, yes and no. Like if you don't have a couple of $100, you don't have a couple of $100. You know, like, but if you are able to gather that money together, then yes, it is.
And one of the reasons that people sometimes end up getting surgical abortions, what are the reasons why someone might delay getting an abortion? Well, maybe they don't know they're pregnant until later on. But for a lot of people, it's, oh shit, I've got to save up a couple $100 because insurance doesn't cover this, Medicaid doesn't cover this. So if you've got to work and save a couple $100, Well, then you're saving up a couple $100, but by the time you hit the benchmark for that, you need a couple $100 more to be able to pay for a surgical abortion, because the further and further in pregnancy you get, the more expensive and the greater risk. Even though abortion is a very safe procedure, obviously a medication abortion is much safer than a surgical abortion. But this self-managed abortion is a really important way in the future, and it comes down, and this was said so perfectly on point in the play. You know, do we trust people to make decisions about their own bodies and their own lives, and what is best for them? And if we do, if we actually believe that we do, then we have to allow them access. What other medication, what other medical procedure is as highly regulated as abortion? Can't be.
And people desire different things from their healthcare. So some people feel most safe going to a clinic and dealing with a doctor. You know, others want to be in the privacy of their own home, want to manage their abortions at home. And cutting off any one of those means that we're not giving people the desired access that they need to. Is it safe if it's not what you desire? You know, like, is it accessible if, again, it's not what you desire, right? So we're also talking about so the education around self-managed and medication abortion is still very low in this country, and we really need to improve educational access to understanding what those things are, so that people have the understanding that they don't have to use things like herbs or pills or powders, because there's recent data from data around self-managed abortion. There has been a shift to people managing their own abortions at home because of a variety of reasons, like lack of judgment at home. Maybe they feel judged going to a clinic, or feel discriminated against, or have had previous experiences of healthcare discrimination. Maybe they like the privacy. You know, maybe they just think it's faster. You know, there's all kinds of reasons. But beyond that, they've also found, when they've looked at the ways that people have self-managed, there's still enough people saying that they have used implements or herbs or pills, powders, or physical force, you know? And we don't want to go back. We don't want that to be how people think that they need to access abortion, because there's no other option for them, right?
And by the way, Grady Memorial Hospital here in Atlanta did have a sepsis ward for abortion before Roe went into effect. So Grady Hospital here. One thing I want to do to help us connect the dots, Janice, moving forward, is to, if you're not familiar with the framework of reproductive justice, I highly encourage everyone to look into it. Reproductive justice moves beyond the language of pro-choice and really talks about creating conditions and environments in which people can choose to create a family or not choose to create a family. And that means connecting the dots to other movements. So we heard in the play about how abortion, you know, we think about single issue voters, but it's really important that we connect the dots to other issues. So one thing that we talk about when we talk about abortion is healthcare. And so do we believe that health is a human right and something that people should be entitled to, something like universal access to health insurance? Who's going to be most affected by abortion laws? It's going to be Black people and other people of color. So we need to think about the Black Lives Matter movement. Who's going to be affected by abortion laws? It's going to be survivors of rape and incest, right, who no longer are able to access these, this procedure because they're going to have to go to the police within days of being raped and make a report. And we know from the Me Too movement that survivors don't always do that. So we need to be able to connect the dots between this single issue of abortion to this web of issues, which is the concept of intersectionality that Professor Kimberly Crenshaw has put forth, and really tie those things together under a larger umbrella of social issues so that all of these dots are connected here. And when we go to vote in June in the runoff elections, which I hope everybody is registered for, and in every other election from that, we need to think about all of those sets of issues together and really be able to recognize our own privilege and positionality, so that if we're in a position where, oh, I could afford to fly to New York if I needed an abortion, what does that look like for somebody different? And I need to vote, in solidarity with them, not just for my own interests.
Right. and what can you do as a Georgian, as a local person? Dabney already talked about abortion funds. We are privileged to live in Atlanta, where we have some of the most vibrant reproductive justice organizations and abortion funds and reproductive healthcare organizations fighting and have been fighting for the rights of people of color, Black people, Black women, LGBTQ persons, and just for the right to abortion. This fight didn't start yesterday. They've been fighting for years and years and kind of sounding the alarm. So support local abortion funds. One of our local abortion fund is ARC Southeast, which actually supports abortions. And when I say supports abortions, they don't just give money for the person to have an abortion. They talk about all of the other things the support that a person might need. Money to rent a hotel room because of the waiting period, transportation, a support person to talk to because maybe they're feeling emotional about moving around to have to, or scared, or
Have to take time off work.
yeah.
Lots of things.
And if you don't feel like financially you have the means to support, there are other ways to support with time. And, you can also donate to your local independent abortion clinics. They are swamped, and could use a lunch. And those kinds of things are helpful, like as a local person supporting local healthcare as well. And so
ARC Southeast.
What's that stand for? Is it?
Access Reproductive Care.
And we sent out an email today with that name in it, if you got our Horizon email list, and there is a link to their volunteer form, and they have a volunteer, if you sign up by the end of the month, there's a training in July for their organization, for anybody who wants to volunteer.
ARC
Southeast.
ARC-Southeast. And I would I'll put a boost in because
Yeah,
I'm on
do
the
it.
board.
Yeah.
The
Absolutely.
Feminist Women's Health Center, which is an independent Black woman-led reproductive justice organization and abortion provider here in Atlanta.
And the final thing I'm going to say is abortion is still legal in Georgia and in the United States. Act as if it is. Talk to people about it. You don't have to convince anyone, but stop the culture of silence around abortion and the culture of shame. Many people that we love and sometimes even ourselves have had abortions, right? And
1 in 3.
yeah, so that's the kind of like life-shifting stuff that you can do as well.
Have a conversation with somebody about abortion.
Yeah, something that somebody from Feminist Women's Health Center said yesterday when the video is out on our email today. She said, it's all going to be up to the states. Your state legislatures, it matters. Your single email matters. If they get 2 emails, if they get 6 emails, that's a lot. She said at these local levels. So, and she said, well, what? There's no bill up. She says, just say, I want to encourage you to legislate for maternal health. Anything that helps maternal health, please consider that legislation. And she said, this is the time to do it because they're all up for re-election and they're listening there to their constituents. So don't think that your voice in the wind doesn't matter, which was really impactful to me because sometimes I do feel like, oh my gosh, I lobby for so much stuff. But I think that's really great to hear from me. I know we're talking a lot of stuff. Any more questions you want to put out? I was going to ask something, and I can't remember what it was. You had said something about the bans that don't, that there are going to be bans of everything, but rape, incest, and all this stuff. You said, what are the things that impacts beyond those people? What else is it?
Yeah, so one of the things we heard in the play was about how the life of the mother has always been considered as an important consideration. And, in recent history, rape and incest exceptions have existed, even among conservative legislators, those have been sort of a bright line. And what we saw with this early abortion ban legislation, we saw those things sort of slipping away. And so rape and incest exceptions, there is legislation that has passed in a number of states. What kind of burden what they've already experienced trauma, and then they have to, number one, disclose, which we know that many survivors sometimes never disclose, sometimes years later disclose. And we saw in Norma's story the sense of timeliness, that timeliness matters. So for rape and incest survivors, it's adding an additional burden to them to have to go through this process and a re-traumatization. And that's the exact opposite of what we want to happen. So we want to be able to have legislation that's going to be supportive of survivors and to be able to provide them with whatever they need as a result of the sexual violence they've experienced. So that's a really important consideration. And again, as we've said, pregnancy is dangerous. And so there are situations in which there are fetal abnormalities. And so that is, you might have, for example, anencephaly or something like that, where a fetus is not going to survive. And there have actually been cases on the international stage in countries where abortion bans exist. And international bodies have found that forcing a person to go through pregnancy and then give birth to a child that will die and is known ahead of time will die is tantamount to torture. And so what does it really mean if we're saying we know that there's a fetal abnormality that is not compatible with life, that we will not allow that pregnancy to be terminated? And similarly, the life of the mother. If the life of the mother is in danger, again, it becomes this question. We heard the conversation about the balancing act, but without the life of the pregnant person, there would not be a pregnancy. And so whose life are we valuing here? And, one thing that hasn't been said, but I think it's sort of part of the subtext of the play is do we value women's lives? Do we value pregnant people's lives? Or are we just a means of production here, reproduction?
Yeah, and we are also, I think one of the interesting parts of the play that I really appreciated was the amount of surveillance that Norma Corby felt as she was pregnant, like about what she was doing. We surveil pregnant people often, and what we're going to see is that in states where abortion bans are present, or abortion is illegal, any miscarriage, suspected miscarriage, or of questionable means, where someone presents at the hospital, there's a likelihood of reporting. There's a likelihood of that person being criminalized for their miscarriage, or if in cases where there might be a suspected abortion. So we don't know what that legal landscape is going to look like for people who suffer a miscarriage or who decide to self-manage their abortions. We just don't know. And we also don't know what it will do, these kinds of abortion bans will do to curtail providers' ability to provide care. Because termination is not just present in an abortion experience. It is, ancillary to pregnancy and all kinds of other procedures. You may see providers, because out of fear of getting prosecuted for all kinds of things, kind of waiting longer to see if a woman's health declines more. There might be more dangerous experiences where we're putting healthcare providers in these kind of, in a situation to make very difficult choices, or to turn clients away or patients away outright,
I'll share one story of a person that participated in a research study of mine a few years ago, and I'm very intentional, and I'm not going to tell you where this took place, so I want you to, in the back of your mind, think about where might this have happened. I'll call this woman Eve, which is not her real name, but she was 19 years old when she was raped by a family friend, and it was her first sexual experience. She didn't know anything about abortion. She began asking around in her community what her options were. She did not report her rape to anyone. She did not go to a health clinic or the police. And eventually she confided in the person that had raped her, who was a family friend. And he gathered together some money, put her on a bus, and she went to a alternative medicine provider who provided an abortion, not a legal abortion and not a licensed medical practitioner. As a result of that procedure, she became very, very ill and in fact became septic and had a perforated uterus, became feverish, was passing blood clots, and her family finally figured out what was going on and took her to a hospital. And in the community in which she was living, there was only one nurse that would take care of someone who was having these post-abortion complications. And fortunately, her life was saved. Very serious complications. They didn't know if they were going to be able to save her. And she did survive, but she was very, very close to dying. I tell that story often. It took place about 5 or 6 years ago. And then I ask people to tell me, where did they think this story happened? So I ask you, where do you think it happened?
Again, you're asking for it.
I'm asking for real.
Again. What'd you say?
Did you say bacon? Okay. Any other guesses? The thing is, it could happen anywhere.
Oh, it could, right, that's why you can't really,
It could happen anywhere. It actually happened in Nicaragua, which is a country that has a total ban on abortion. So I mentioned that this young woman was raped. There's no exception for rape or incest in her country. She could not have gotten a legal abortion. She did not report her rape. So even if there was a rape and incest exception, she wouldn't have been able to get an abortion because she didn't report it. She didn't know anything about emergency contraception. And because she didn't go to a healthcare provider after her experience, her pregnancy could have been prevented, right, if she knew about emergency contraception. But when you live in a community where we don't talk about comprehensive sex education and we don't talk about these things, people don't have this information, right? And so, as much as, Suba said, we don't know what the legislative world is going to look like, we do know what it looks like when people don't have access to abortion. And that is that abortion doesn't stop.
Yes.
It continues and it continues in dangerous ways.
And we do know that it becomes more and more of a criminalization process for the women.
And the providers.
And the providers and anyone who helps them. You don't necessarily have to be seeking an abortion or be an abortion provider to be under some of the state bans, for example, SB 8 in Texas, to be brought under suit, right?
You could be an Uber driver
Yeah.
taking a woman to a clinic.
Right. And the last thing I'll say is we're public health social scientists. We think about the healthcare consequences of abortion bans, and there is no evidence in any country that has an abortion ban that legislating abortion into extinction is healthy for anyone, for families, for couples, for anyone in society.
In fact, it's the opposite.
It's the
Because
absolute
maternal
opposite.
mortality goes up.
And there's no evidence that there's any healthcare or scientific basis for overturning Roe.
Now, how did you, or how are people getting this message out to legislators? How do they learn about this? How do they learn the truth? Or
Well, we have some great groups in Georgia that work with the Rise Center and with the Emory Rollins School of Public Health. For example, Amplify Georgia is an incredibly great group. And what we do as researchers, and I just participated in this because recently there was a telemedicine ban on the books in Georgia. So because they were concerned that, maybe in-person abortion would no longer be legal, but people would try to use telehealth or telemedicine means to get medication abortion, they just tried to put forth a telemedicine ban in the last legislative session. And we worked with Amplify Georgia to create research-based one-pagers for legislators so that they would have all the information that they needed to be able to testify against this.
The other thing I'd add is that and state legislation is extremely important.
Right.
Unfortunately, right now, the legislature in Georgia is not moving towards ensuring access to abortion or reproductive health justice and rights for people. But there is legislation at the federal level, the Women's Health Protection Act, and it's stalled right now. So there are some opportunities, and I think especially, and this is any day now, right? It's June 11th. This case is going to be decided by the end of June. So the news can drop any second. And as soon as it does, there are states where abortion is going to be illegal immediately, which is why we need federal legislation protecting abortion rights in this country. And so we could have that. And we need more, right? We need more than just access to abortion, because abortion is just one piece of reproductive health. It's not everything, right? We also need contraception. We also need emergency contraception. There's tons of sexual and reproductive health stuff that we need. And this is just one piece that has gotten a lot of attention, justifiably, but there's a lot else that we need.
We need medication expansion that covers abortion. There's a lot that we need to think about, and there's a lot that you all can do to keep this on the radar of both your state and federal legislators.
Anybody have a final question? Thank you so much. We have a bunch of different
If you really want to wonk out on this stuff, we have published a paper that is our reverse engineering, we like to call it, of the Georgia heartbeat ban, the Georgia early abortion ban. And I also have a paper which is a more detailed story of the story of Eve. So if anybody's interested in that, happy
Well,
to
send
share.
it to me and I'll put it on a research page and get it out.
Yeah, and we can also, I can give you the page of the Rise Center, which links to all of
All
our
that stuff.
publications.
Yeah.
And, if you want to understand more about the difficulties that people face in getting abortion while it's legal in the United States, Carol Joffe's book, Obstacle Course, is an incredible read, and so is Diana Green Foster's book, Turn Away, which is all about
Turn away.
which is about her study that started about a decade ago, looking at the health consequences over a long period of time of women who were denied abortions. So,
Thank you so much.
thank you.